Good afternoon, everyone, and welcome to today's event hosted by Region 10 chapter of HFMA. Today's webinar is part 2 of a 4-part Medicare Bootcamp series. Today's topic is Medicare Fundamentals. I would like to welcome today's guest presenters. We have Bragg, Hemme, and Sara Iams. Bragg is a shareholder at Polsinelli PC. In order to assist healthcare clients address their targeted business concerns, Bragg draws on a wealth of practical experience and a solid understanding of the industry gained during her time as both external and internal counsel. Her experience includes advising clients regarding the complex and ever-changing federal and state regulatory environment, including Medicare, Medicare Advantage, and Medicaid reimbursement, enrollment, licensure, and certification issues, regulatory compliance, and fraud and abuse. Sara Iams is an associate also at Polsinelli PC. Sara collaborates with clients and colleagues to navigate the complex healthcare regulatory environment. She regularly counsels clients on Medicare and Medicaid reimbursement, enrollment, fraud and abuse, and other regulatory compliance matters. So we have a full presentation. So without further delay, I'd like to hand it over to our guest presenters. Bragg, I believe you're up first.
Yes, thank you so much, and welcome everyone. We've done this program for a couple of years in a row, and it's a great high-level summary of Medicare structure and how the various parts of Medicare work. We're going to spend probably the most significant amount of time talking through the overall structure and then parts A and B of Medicare, although we will touch on parts C and D. And there is also a lot of things that are evolving in the Medicare space. And so we'll spend some time talking about evolving models and also talk about overpayments. It's a significant risk area for a lot of different providers and suppliers. And so we'll spend some time on that. And to start, I'm going to turn it over to Sara to talk about the structure of the program, and did want to point out that we submit our materials and bios a month or so in advance of the materials, but recently Sara was promoted to shareholder, so we're happy to have her, and I will turn it over to Sara.
Thank you, Bragg. As she said, we're going to get started with talking about the structure of the program, and really starting at a high level here. We're going to go into some more depth into each of these segments of Medicare throughout the presentation, but the program and the benefits in particular are divided into 4 distinct parts, and they're most often referred to as parts A, B, C, and D, which by themselves don't really tell you very much. Part A covers inpatient hospital stays, skilled nursing facilities, most home health benefits, and hospice care. For most beneficiaries, there's no Part A monthly premium. They are entitled to premium-free Part A by having paid into Social Security. But the Part A benefits are subject to a deductible of about $1,300. And don't worry, we are going to go into a lot more detail about what all of these are, but I just wanted to start at a very high level here. Part B covers generally physician visits, outpatient hospital services, durable medical equipment, certain drugs, diagnostic tests. They're also subject to a deductible from the beneficiary's perspective of a little less than $200 every year, and cost sharing as well. Part C is also known as the Medicare Advantage program. It's a growing program through which beneficiaries can enroll in a private health plan, such as an HMO or PPO plan that you might have through an employer, and they receive all Medicare covered benefits that would be provided under Parts A and B through that private plan. So if a beneficiary is enrolled in Medicare Advantage, they're not also enrolled in Parts A and B. It's essentially a replacement, and it captures both of those through a private Medicare Advantage plan. And finally, Part D, it's a voluntary outpatient prescription drug benefit. And like Medicare Advantage plans, Part D is offered through private health plans that contract with the government, contract with Medicare. But unlike Medicare Advantage, the benefit is in addition to Parts A and B. And those plans, these prescription drug plans, are offered as standalone plans, or they can be offered in connection with a Medicare Advantage plan. So those are called MAPDPs, Medicare Advantage Prescription Drug Plan, sort of collaborative plans there. Just to give you a general sense of the scale and size of the importance of the Medicare program, all of these parts together as part of the overall federal budget. In 2017, Medicare represented 15% of the federal budget, with spending totaling about $702 billion, which I was shocked to see was up from $425 billion just 10 years ago. So in 10 years, an expansion of about $250 billion. So it's growing, and growing in large part due to Medicare enrollment numbers. So we've got a large portion of the population aging into eligibility, and then just general increased use of services and the intensity of care, and rising cost of healthcare across the board. The parts really describe the framework for the covered benefits, but if we're trying to understand the system as a whole and kind of how it works together, one way to think about it is in terms of these 4 basic requirements. And I have basic in quotes because, as you really get into the weeds on any of this, they're not actually that simple. But to obtain payment from the Medicare program, there has to be an eligible and entitled beneficiary, a properly enrolled provider or supplier, a covered service under Part A, B, C, or D, and the provider or supplier has to meet all the relevant coverage and payment conditions for the individual service that you're furnishing. So we'll go through each of these in more detail, but we just wanted to kind of provide you a visual of how this works. You have to have each of these parts in order to get to the dollars at the end. The first piece is a relatively obvious one. You have to, for Medicare to pay for an item or service, the person who receives the service has to be an eligible and entitled beneficiary. So who falls in that bucket? First, and probably the one most people recognize, is that a person becomes eligible for Medicare when they turn 65. You might hear politicians talk about increasing that eligibility age from time to time when you think about sort of the long-term viability of this and the amount of money that we're now spending on it as a percentage of the budget, but that hasn't happened. We haven't had full-scale reform of Medicare yet in any capacity, so that does come up with frequency, but we're still at the 65 years as the eligibility age. You can also become eligible if you're diagnosed with what's called end-stage renal disease, or ESRD, or if you have a disability and you're disabled for at least 24 consecutive months. You might notice that we've used both terms eligible and entitled. Those terms are used a lot of times interchangeably, but they do have distinct meanings for Medicare purposes. And that's mostly because a beneficiary can be eligible, meaning they fall within one of these categories, but they might not yet be entitled to Medicare benefits, either because they've yet to enroll or maybe because they're subject to a waiting period, like beneficiaries with ESRD who have a 3-month waiting period. In most cases, people who are eligible are also entitled or about to become entitled, but just beware of the distinction. And if a person happens to be eligible but isn't yet entitled, just know that Medicare, that's sort of a no man's land, and Medicare wouldn't pay for the service in that case. The next important requirement is that you have a provider or supplier who is properly enrolled in Medicare. And these are actually also 2 distinct terms. People frequently use the term healthcare provider generally, but Medicare, for Medicare purposes, they are defined uniquely and treated differently under a lot of different Medicare rules. A provider is generally an institutional healthcare facility. It includes all types of hospitals, skilled nursing facilities, home health agencies. You might notice it sort of lines up with the general description of Part A that I gave previously. It's not a perfect lineup, but it does line up pretty closely with that. A supplier, on the other hand, is basically everything other than a provider. It includes a lot of different types of non-institutional entities, and it also includes individuals. So between both of those, it's physicians, physician groups, ESRD facilities, independent diagnostic testing facilities, laboratories, and the like. The reason it's important to remember this distinction between those two is that some statutory and regulatory requirements apply only to providers, not suppliers, or vice versa. So if you're ever looking at Medicare rules, particularly in the statute, they're very careful and do distinguish between provider and supplier in that context. So just be aware of that as if you're ever doing research in the statute or in the regs, in the regulations. So the enrollment requirements for providers and suppliers vary, but in general, both providers and suppliers have to submit an application. In most cases, if you're a provider, you would submit the CMS Form 855A. And then if you're a supplier, you submit one of several different forms, depending on the type of entity or individual that you are. But it can be the 855B, the 855I, or 855S. There are exceptions. In some cases, ESRD facilities, for example, they enroll using the 855A, which is typically for providers, but they're classified as suppliers for all other purposes. So that's not a perfect one-to-one either, but something to be aware of. Providers enter into formal agreements called provider agreements, not surprisingly, that certifies that the provider will essentially follow all the rules. And the agreement outlines a number of requirements that are specific to providers, not suppliers, related on how they provide and bill for services. Some suppliers also enter into what's called a participating supplier agreement, but that's distinct from a provider agreement. In addition, some types of providers generally and some types of suppliers have to go through what's called the survey and certification process to be enrolled. These providers and suppliers have to meet what are called Medicare conditions of participation, sometimes called conditions for coverage. And these are regulations that outline the basic requirements to enroll. CMS typically contracts with state agencies to conduct the surveys and evaluate compliance with all of these regulations. Sometimes the surveys are done by third parties, like you may have heard of the Joint Commission, and there are other entities that are authorized to perform those surveys on behalf of the state. And a lot of times people will have that. A lot of times the provider or supplier may opt for the Joint Commission or other entity because they can perform the survey more quickly. On an initial enrollment, they can perform it more quickly than a lot of times the state can. The actual requirements and the conditions are not generally service specific, so they're not issues that relate to the type of service that the patient received, but they're more general and they relate to the operation of the provider. They involve things like personnel qualifications, the physical facility, how it's set up and constructed, patient rights, infection control, and things of that nature. If the provider or supplier has completed their enrollment form and they've met all the conditions as surveyed, then CMS will approve them to provide the services and to receive payment. There are sometimes surveys that happen after the initial enrollment period, so you can have an unannounced survey take place, say if you're a hospital, for example, where they will come in and evaluate the compliance with the conditions for participation, make sure you're meeting them on an ongoing basis. If at any point that type of survey happens, or it becomes apparent that the provider isn't meeting the conditions, Medicare can decide to revoke or suspend the enrollment and the billing privileges, and that can be really devastating for any provider who depends on Medicare dollars or who depends on enrollment as a requirement for their commercial payer contracts, as commercial payers often require in their contracts that you be certified and eligible and enrolled in Medicare. So the violations typically, to get there, the violations typically have to be fairly egregious and typically patient safety concerns in order to warrant revocation, but it is possible. So these conditions are incredibly important to meet and monitor on an ongoing basis. The next requirement is related to having a covered service. So we have a beneficiary and we have a properly enrolled provider supplier. Now we have to make sure we have a covered service. And I would argue that this is probably the most complicated part of this. Medicare's baseline requirement for covered services is that they are reasonable and necessary. That seems like a straightforward concept. It's not, especially trying to define what is reasonable and necessary, what is medically necessary. But if it's not, if CMS has determined or Medicare has determined that it isn't, there is no coverage and there's no payment. But beyond that initial baseline requirement, to figure out if you have a covered item or service, it has to fit into what's called a benefit category, a Medicare benefit category. And these are outlined in the statute. And when we've done webinars in the past on how to conduct Medicare research, this is our starting point for most of our research questions. We have to find the statutory benefit category for the item or service. And that's really important because the benefit category is tied to very specific regulations and very specific policies that govern, in what circumstances Medicare will cover and pay for it. So figuring out which benefit category you're in, making sure there is one that fits your item or service is really important. And as you're doing this, figuring out if you have a covered service, there is a list of non-covered services that I'll show you that list in just a couple slides here. So when we talk about benefit categories, it's not a term that you might just automatically know. Benefit categories include this full list and more. This is not an all-inclusive list necessarily, but it really covers inpatient hospital services, physician services. Those are probably two of the biggest, but also everything else here: home health, DME, durable medical equipment, hospice, PT, physical therapy, occupational therapy, the full list. And as I said before, Medicare also, by statute, outlines what's not covered. And these are things like hearing aids, eyeglasses, dental services, personal comfort items, and there's some others as well listed there. So if you have coverage for an item or service, meaning it fits in a benefit category, it meets the coverage regulations, and it satisfies the requirements for medical necessity, the last step is really confirming that all the payment conditions are met. And these are the rules that define, not only a payment methodology, but also any additional prerequisites to payment. And probably between the covered service and the payment conditions together are really the two keys to making sure you can ultimately get paid. These rules, most of the conditions of payment are service specific. So for example, for diagnostic tests that are furnished in a freestanding or non-hospital setting, an example of a condition of payment might be the requirement to furnish that test under the specific level of physician supervision. And without proper physician supervision, Medicare doesn't cover it or pay for it. So that's just an example, but other payment rules are more general and administrative in nature. For example, I have at the bottom here of this slide the concept of reassignment. And this is if physicians employed by a hospital and wants the payment for the physician's Part B professional services to go to the hospital directly, that physician has to properly, quote unquote, reassign his or her right to Medicare payment to the hospital. And there's a whole set of rules along with that, and when reassignment is allowed and a particular form that the physician has to fill out to make that happen. So this slide, it's a lot of information, a lot of sites, but it's really just to help you. This is more for reference for you afterwards, rather than going into any detail about these specific regulations that we've listed here, but more to serve as a reference for you to understand what payment conditions apply to specific types of services. So just quickly to recap, if all four of these conditions are met, you ultimately get to payment. And when we get to actual payment, it gets even more complicated. But we can start to talk about now the actual payment mechanisms and how Medicare pays for various services under Parts A, B, C, and D. And I will turn it to Bragg to talk about Part A first.
Great, thanks, Sara. And this presentation is often more fun to give live because after that first trunk, you can kind of see everybody's eyes roll back in their head because of how some would think overly complicated these programs are, but Sara laid it out nicely in the various things you have to think about to get to payment. I'm going to go through Part A. And the reason why we break it out by part and then by facility within each part is because it is really, really, really important to make sure that you, when you're analyzing payment and analyzing whether or not you or your facility has appropriately received money from the Medicare system, it's really important to analyze it under the proper section of Medicare in order to be looking at the right rules. And so, and then within that, there's some providers like hospitals, for instance, that bill under both, all of the parts. So they bill under Part A, Part B, Part C, Part D. So then you have to figure out what service you're talking about as well. And so there are basically four main areas that are covered under Part A that we'll talk about: inpatient hospital services, skilled nursing facility services, home health services, and hospice services. And while they're all covered under Part A, each of them have their own payment methodology and requirements. So starting with inpatient hospital, when we talk about inpatient hospital services and supplies, we are generally talking about general acute care hospitals. There are other types of hospitals that have a different payment structure, so we need to make sure we know what type of hospital we are. So general community hospitals and certain specialty hospitals are covered under the inpatient hospital payment rules, and then we'll talk about the other types of facilities in a moment. Generally speaking, for inpatient hospital stays, patients are limited to 90 days of coverage, Part A coverage, per spell of illness, and that date starts on the date of inpatient hospital admission. And there are also 100 days of extended care available per spell of illness. And then you also, each beneficiary gets 60 lifetime reserve days that they can draw on for any long hospital stays. From a deductible standpoint, the beneficiary deductible and copay obligations don't kick in until day 61, and then they go up over time. So the longer the stay, the more deductible and copay obligations the beneficiary will have. The next slide, we're talking about the other kinds of hospitals. So long-term care, long-term acute care hospitals, or LTACs, critical access hospitals, psychiatric hospitals, rehab hospitals, and children's hospitals all have their own rules and own payment methodologies. And some of these facilities are also located within a general acute care hospital. And so then you have to pay attention to another set of rules that we're not going to talk about today. But they have their own set of rules generally, and then if they're co-located within another hospital, because of the payment discrepancies between them, these are facilities that CMS has agreed don't really fall within the calculus that they do to come up with the inpatient hospital payment system. And so they've separated them out. They've come up with systems for each of them that are separate, oftentimes more than what you would get paid in the inpatient IPPS. And so Medicare gets concerned when you're sharing facilities that you're not, sort of moving patients around to different units just to take advantage of those costs. So make sure you pay close attention on where you are and what type of facility and the like. So moving to skilled nursing facilities under Part A, the Part A coverage applies just to skilled nursing facilities. It does not apply to custodial care, assisted living, or general nursing care. Those items are not typically covered by Medicare, and it's just in the skilled setting. You're limited to 100 days of skilled nursing care per spell of illness. In order to get the SNF coverage, however, you need to have what's called a 3-day qualifying hospital stay before that. There are some exceptions to that rule that are growing out of evolving payment systems and the fact that hospitalizations now don't necessarily take as long. You can have, a 2-day hospital stay and then get adequate follow-up in a skilled nursing facility. So they're starting to realize that there's some value in going to different settings for care to reduce costs and to help the patient. So there are some exceptions to that, but generally speaking, you still need a 3-day inpatient stay before a SNF admission. And not everyone knows that they need a SNF stay, so they might be discharged and then need to go back into a SNF, but that would have to happen within 30 days of discharge from the hospital. And in order to get skilled nursing care versus regular nursing care or in a nursing facility, there are certain medical necessity certifications or recertifications that have to take place on routine intervals to just maintain record that the physician continues to believe that this SNF level care is medically necessary. And home health services. So this is intermittent nursing and therapy services and supplies that are furnished in the beneficiary's home. You have to be confined to your home or an outpatient setting, and you have to receive treatment from a physician under an established plan of care that determines that you need intermittent skilled nursing care or physical therapy or OT or speech language therapy, and that there's an ongoing need for that. So also we need to pay attention to a distinction with home health between Part A and Part B. So Part A will cover the first 100 home health visits if the beneficiary was discharged again from a 3-day or longer SNF hospital or SNF stay, and you were discharged from that stay within 14 days of the first home health visit. Part B will cover visits over 100 or if you don't meet the Part A criteria. And so you'll have to monitor patients over time to see what benefit you're billing. If you only one applies, obviously you'll continue to bill that, but for patients that start off on Part A, they could flip to Part B during that home health spell of illness, so keep an eye on that as well. For hospice services, these are services that are provided to terminally ill patients where they elect hospice care, and this is to elect hospice care means that the patient is relinquishing their right to Medicare payment related to the treatment of their terminal illness for which you're electing hospice. So you forego your regular Medicare benefits and get hospice benefit. You can still get treatment for things unrelated to the terminal illness, but for the terminal illness, you are foregoing treatment and get palliative care instead. And this is done where the physician determines that a beneficiary is terminally ill, which means a prognosis of 6 months or less, and they have an established plan of care. You'll see plan of care requirements for most of the different payment methodologies, and then benefit periods. And this does not mean that a patient has to die within 6 months. It just means that we do continue to get recertified to make sure that the patient still qualifies for the benefit. So it could be in certain cases where the patient says, you know what, I'm not ready for this. I'm not ready for hospice. I want to go back to treatment care. And so you can get rid of your hospice benefit and go back to full Medicare coverage. It could be that, you know, some new treatment comes out on the market and changes the prognosis for the patient. So the physician can decide at that time that they're no longer eligible for hospice. So there are certain periods that we require certification and recertification to make sure that they are an ongoing candidate for hospice care. So moving from the coverage criteria for those services and into, okay, we qualify for everything, how do we get paid? And we've talked a little bit about the prospective payment system, but Medicare has really moved from cost-based or fee-for-service-based methodology into paying most of the Part A providers under a prospective payment system, which is a predetermined flat rate based on the beneficiary's diagnosis. And so for the general acute care hospitals, this is based on a rate that represents the average national cost to treat a beneficiary with similar diagnosis. So those are grouped into what are called diagnostic-related groups, or DRGs. And you get that same payment regardless of your actual cost, regardless of length of stay. And the idea behind this is that where you do fee-for-service care, and the more the hospital does, the more money they're going to make, there are obviously built-in incentives to increase the amount of care provided. And the idea in moving to a preset amount is that hospitals will be more efficient, will not add unnecessary procedures and the like, so because they'll be incentivized to reduce costs under that DRG payment. There are certain payment adjustments under current PPS models, which we'll talk about in a bit, but based on quality and then certain other adjustments for certain facilities. So big drive for all of the Part A providers to move from a cost base to a PPS system. So I'm not going to go into this slide with much detail. It's highly mathematical, but this is just a short sort of stepped version of how they go through it. So you get the diagnosis off of the medical record that then correlates to a MSDRG group that's weighted and then multiplied by a standard amount that's set by CMS. And then you get the various adjusters. So if you have a disproportionate share facility or you do certain resident teaching activities, additional payments can be made. For certain high cost patients, there can be outlier payments, and there's a whole other set of regulatory requirements to get outlier payments and figuring out how much that may be. But that covers patients who fit into one diagnostic group, but for whatever reason turn out to be a much higher cost patient. And there are a variety of other special payment adjustments that can come up. And so once they go through that calculus, they determine what the payment should be, and you are paid. There are different PPS methodologies for different providers. So there's one for the general acute care hospital. There is a prospective payment system for SNF. There's a prospective payment system, which is a per diem rate for hospice. There's a separate per diem PPS for inpatient psychiatric hospitals, all accounting for the various cost structures that go into caring for those different patient types. There are still parts of Medicare payment that are based in cost. And these are largely around facilities that just have a different structure. So a lot of rural facilities, critical access hospitals, rural referral centers, hospitals that are struggling to stay afloat, but where we need access to care, they still pay on a reasonable cost basis. They have not moved those facilities to PPS. And then blood clotting factors for hemophiliac patients, bad debt for hospitals. Bad debt is an amount that Medicare will pay to reimburse patients for, or not patients, excuse me, to reimburse facilities for co-payment amounts that are deemed uncollectible. So there's a way to recapture some of that money for patients that don't pay their co-insurance amount. Nursing education programs and organ acquisition costs are still based on costs. And then we will go back to Sara to talk through Part B.
Thanks, Bragg. So as Bragg just did, I'm going to go through Part B and talk a little bit about the covered services that are included in Part B, and then talk, just focus on a couple of Part B payment methodologies. We don't have time to go through all of them, but we'll focus on physician payment and then hospital outpatient payment as well. Okay, so we talked about this a little bit, but when we talk about Part B, we're talking about a really broad group of items and services. It includes everything from physician services to hospital outpatient services, to surgical services in freestanding ambulatory surgery centers, as well as certain drugs. It's really a little bit of everything. And I think, as I said at the beginning, it's sort of everything other than what a provider, Part A provider does. So it's a really broad category. The first category we'll talk about is professional services. And these are your typical physician office items and services. They're furnished either by a physician or a non-physician practitioner, like an advanced practice nurse or a physician assistant. It also includes physical occupational therapy, the professional component of certain diagnostic tests. And for example, there might be a patient might get an MRI at an independent diagnostic testing facility, and a physician interprets the results of that test. That professional component is a Part B professional service. You also have the Part B benefit category for what are called Incident to services. These are services that are furnished incident to the professional service of the billing physician or practitioner. And what that means is you might, for example, have a registered nurse. Registered nurses aren't authorized to enroll in Medicare, and they can't bill Medicare independently, but they do provide services on behalf of the physician in a physician's office. And as long as the physician is properly supervising that person and certain other conditions of payment for Incident to services are met, the physician can bill for the registered nurse's service as an Incident to service under the physician's name, and then the physician receives full payment under the fee schedule as if that physician had performed the service. So it's an interesting way to allow physician offices to make use of non-physician practitioners like registered nurses who can perform those underlying services, and yet the physician who's supervising can ultimately bill for it. The Incident to category also includes drugs, and we'll talk about that a bit later. Other very large category of Part B services is hospital outpatient services. For Medicare purposes, there are really three main settings where hospital outpatient services are delivered: emergency room, hospital observation unit, which is essentially where you would go if you present to the ER and the treating physician isn't sure whether you need inpatient care yet, so they admit you to the observation unit for their monitoring. And then the last setting is the traditional hospital outpatient department. And in a couple of minutes, we'll talk more about hospital outpatient departments and exactly what that designation means. In terms of services that fall within this benefit, it's very broad. It includes all the expenses associated with operating the hospital outpatient facility, such as use of the actual treatment room or supplies or equipment, as well as the actual underlying services themselves, so like anesthesia, the expense of what's called the technical component of a diagnostic test, meaning the expense associated with operating an X-ray machine or an MRI, certain other therapeutic services, and some laboratory tests. And I guess I just make one clarifying point here. Obviously, you have physicians and other clinical professionals that furnish services in hospital outpatient departments. You wouldn't have a functioning hospital department without them. But we just talked about those Part B professional services that a physician is furnishing in the hospital. Those are still a separate benefit category from the hospital outpatient services, and the two are billed separately. So, for example, if you had a patient who has a physician visit in a hospital outpatient department, the physician gets to bill Part B for the actual professional service that represents the visit and the time they spent counseling the patient, treating the patient, whereas the hospital bills Part B for what is the facility, what's called the facility fee. And that allows the hospital to collect a fee for the use of the treatment room and the general overhead associated with that patient visit. So in that case, the hospital outpatient service that Medicare is billed for is really the use of that room and the overhead. So that's just one thing I wanted to point out as we talk about these two things back to back. In addition to those main categories of professional services and hospital outpatient, Part B also includes durable medical equipment and prosthetics, orthotics, and supplies. This is typically referred to as DME or DME POS. When we think of this category, think of DME like wheelchairs or CPAP devices, home oxygen equipment. It can also include drugs that are used in connection with an implantable item of DME, and that's like an infusion pump, for example. And as I said, it also includes prosthetics and orthotics, like artificial limbs. The key coverage criteria for DME is that they have to be used in the home. So when an item is covered as DME and under the DME benefit category, it's when a patient is at home. So that might follow a hospital discharge, for example, where a patient has a hip replacement surgery and then they need medical equipment to rehab at home or need a wheelchair to be mobile at home. That's when the DME benefit comes into play. Another big Part B category is for diagnostic tests and diagnostic services, so X-rays, MRIs, EKGs, mammograms, sleep studies, and a Part B diagnostic test has two parts, and I've talked a little bit mentioned both of these, but you have the professional component, which is the physician or other practitioner's interpretation of the diagnostic test results. So holding the X-ray up, looking at it, and deciding which bone is broken. And then you have the technical component, which is the basic test itself, the cost of using that diagnostic equipment. And when we're talking about this benefit category, the Part B diagnostic service benefit category, we're talking about tests performed in a freestanding clinic, like an independent diagnostic testing facility or IDTF, sometimes physician offices, but most often IDTF. And so keep in mind that if a diagnostic test is performed in a hospital outpatient department, then that technical component becomes a hospital outpatient service as opposed to a freestanding diagnostic test. And again, not to beat a dead horse here, but as we've talked about, this is important because either hospital outpatient benefit category and diagnostic test benefit category are separate, so they're subject to different Medicare regulations and rules. So in this case, the setting in which the service is performed defines the benefit category and defines the rules that apply. Ambulatory surgery centers, or ASCs, also furnish services covered and payable under Part B. ASCs provide outpatient surgical procedures, so they are limited to performing surgical procedures that don't require hospitalization or an overnight stay. So these facilities operate independent of hospitals or physician offices, and they are subject to their own separate enrollment requirements and rules, although they can be located and often are located near hospitals or physician offices, and even in the same building, as long as they maintain distinct space. I also wanted to touch on Part B drugs. It does cover some drugs. We already spoke about Part B coverage for drugs when they're furnished through an item of DME, so through the infusion pump, for example. Medicare will cover drugs under Part B in that context. The two other ways that Part B covers drugs are under the Incident to benefit. So physicians can sometimes provide services with the assistance of nurses, as I mentioned, under the Incident to benefit before. And those professional services performed by the nurse are then billed by the physician. And drugs can be billed in a similar way. So when drugs are furnished in a physician office, for example, they might be injected by the physician or by a nurse, and they're billed as a supply that's furnished incident to that physician's professional services. So that's another big category. The final way in which Part B covers drugs is through individual benefit, statutory benefit categories. So there are certain categories like vaccines, oral chemo, blood clotting factors, and other immunosuppressive drugs that actually have their own line in the statute and have their own benefit category. You'll see at the bottom of the slide here, one thing to keep in mind is that if Part B doesn't cover a drug because it wasn't furnished in the right setting or some other aspect of Part B coverage is not met, it could be also covered under Part D, which we'll again talk about in a little bit. This is another, just a really catch-all for all the other Part B services that we don't have time to talk about today. It captures both services like lab services and dialysis services, as well as the Part B supplier types. So anytime you see any of these services or supplier types, you're operating under Medicare Part B. Okay, and so now we want to move on from describing the actual Part B items and services in the benefit categories to talking about how Part B providers and suppliers actually get paid, as Bragg did. There, under Part B, as with Part A, there are a number of methodologies represented. Many suppliers are paid under a fee schedule, which provides payment for individual services and items on an individual basis, so by volume, essentially. And that includes physicians and non-physician practitioners, DME, POS suppliers, and clinical labs. They all get paid on a fee schedule. But Part B also includes prospective payment methods for hospital outpatient services, for ASCs, and for dialysis providers. And they also incorporate different cost-based methodologies. So for rural health clinics, for example, their all-inclusive per visit rate is a cost-based methodology. So it's really all over the map and depends very much on the type of service and the type of provider. In the interest of time, I just want to focus first on the physician fee schedule. This pays, again, for the individual professional services of physicians and non-physician practitioners. Each professional service is assigned a code that describes the service, and you'll hear people refer to these as HCPCS codes or CPT codes. And Medicare assigns a payment rate to each of those codes under the fee schedule. And if you're ever looking for, how much does Medicare pay for X physician service, there is actually a fee schedule lookup tool on the Medicare website that you can go in and enter the code and where you live, because there's a geographic adjustment to it, and see the reimbursement amount for that particular service. The payment rates specifically are derived from what are called RVUs, or relative value units, and that just takes into consideration the amount of work and the overhead expenses that go into the service. Under the fee schedule, as we've noted at the top here, the physicians receive 100% of the fee schedule amount from Medicare, but 80% of that comes from Medicare, 20% comes from the beneficiary, typically. Other types of practitioners, non-physician practitioners who can enroll and bill independently, nurse practitioners, physician assistants, for example, they receive only 85% of the fee schedule. So just something to be aware of, and that Medicare takes into account the type of practitioner to determine the amount under the fee schedule. The fee schedule is also affected by certain other factors. One thing is the site of service differential in physician payment. And the concept there is that physicians are paid slightly more under the fee schedule when they're furnishing services in their own offices versus when they're furnishing services in, for example, a hospital. The reason for that is just attributed to the overhead expense, essentially. When furnishing services in their own physician clinic, the assumption is that the physician is bearing the brunt of that cost and so is entitled to some additional payment. Whereas when they're furnishing services in a hospital, the hospital is paying for those overhead services. So Medicare does not pay the physician as much. There are other adjustments too, as Medicare moves toward quality and performance-based payments, and I think Bragg is going to touch on that in a little bit. I also wanted to focus briefly on hospital outpatient prospective payment system. Under this method, services furnished in the hospital are classified into what are called ambulatory payment classifications, or APCs. So as Bragg talked about, the inpatient prospective payment system, where the payment's based on the DRGs, or the diagnosis-related groups. Now, under the hospital outpatient side, we're looking at APCs. So as if you needed more acronyms to remember, they're different depending on whether it's inpatient or outpatient service. The way it works is that services that are similar in clinical intensity and resource utilization are all assigned to the same APC rate. And there's actual prospective payment bundled rate tied to each individual APC. For example, an MRI would have an assignment to an APC, and that might match or be slightly higher than the APC assigned to an X-ray. And so again, it operates very similarly to the hospital inpatient PPS, but it's just tied to the service rather than the diagnosis code. One important concept that I wanted to address related to hospital outpatient payment is the provider-based concept, which you've probably heard of. To qualify for payment under the OPPS, the location or the facility in which the service is furnished has to meet what are called the provider-based rules. And this essentially means that the facility has sufficient connection to a main hospital, and Medicare measures this through several criteria. Under the rules, the provider-based department can be either on the campus of the main hospital, within 250 yards of that main location, or off campus, as long as it's within 35 miles of the main provider or meets certain other criteria to demonstrate that it serves the same patient population. But at the core, regardless of whether it's on campus or off campus, both have to meet certain criteria to demonstrate that they are integrated with the main hospital location. There are certain rules that are specific to on-campus and off-campus locations, but there are some general criteria on this slide that are common to both. So the department has to operate under the main hospital's license if that's allowed under state law. The department has to be held out as part of the main provider and be both clinically and financially integrated with it. And generally it just has to act like part and parcel of the hospital, meaning it meets all of the hospital conditions of participation that we talked about when we talked about enrollment, and it holds itself out and has signage to indicate that it is a hospital department. If all of these provider-based criteria are met, then the hospital can treat that on-campus or off-campus facility as part of the hospital and bill under the OPPS. Why does it matter? And it matters because there's a financial benefit to receiving payment under the OPPS. And hospitals, we talked a little bit about this, but hospitals generally receive higher payment for services furnished in an outpatient department as opposed to, say, a freestanding physician clinic. And earlier I talked about a situation in which a patient would go in for a visit at a hospital outpatient department, and as a result, Medicare is billed for both the facility fee from the hospital and the professional fee from the physician. The amount that's paid out in that hospital scenario is higher than if the patient had just gone into Dr. Smith's office down the street that's unaffiliated with the hospital, not provider-based. In that case, only the professional service is billed under the fee schedule. There's no facility fee. So at the end of the day, there's more reimbursement, or at least historically, there's more reimbursement attributed to the hospital under the OPPS. This was the case for all provider-based departments, both off-campus and on-campus, until recently, when Congress and CMS noticed that many hospitals were buying up freestanding physician offices and converting them to provider-based departments to capitalize on that payment differential. And they began focusing on what they called the site neutrality effort, meaning essentially an effort to make Medicare reimbursement amounts for the same service neutral across settings. It started with the Bipartisan Budget Act of 2015, and it's been carried forward through CMS rules. Basically, the statute, it calls for a site neutral payment for any new off-campus provider-based departments that came into existence after November 2nd, 2015. For any of those sites, Medicare now pays them under what they call a site neutral policy that's based on the physician fee schedule and overall presents a pretty substantial reduction in payment to those outpatient sites. For the time being, all on-campus provider-based departments and off-campus provider-based departments in existence prior to November 2015 continue to be paid under the OPPS. So this is, this policy change in the last couple of years has created a lot of confusion and administrative burden for hospitals that are trying to bill for services at various sites and figure out how to do it right everywhere. But it is kind of the direction that CMS is moving to try to eliminate payment differentials across settings. And again, just another catch-all slide here, because we don't have time to talk about all of them. This is a summary of other payment methodologies under Part B. So for example, we've got ESRD facilities and ASCs that have their own prospective or bundled payment methodologies that function similarly to the hospital inpatient and outpatient systems. And then you've got DME suppliers and others, emailed services, for example, that are subject to their own fee schedules. I will turn it back over to Bragg to give us an overview of Part C.
Thank you, Sara. Thanks, everyone, for sticking with us. Part C, as Sara mentioned, is kind of Medicare Advantage program. And this is where CMS contracts with private plans, the United, Humanas of the world, to cover the Medicare beneficiaries' medical benefits. And Sara, if you could go to the next slide. Enrollment in Medicare Advantage plans is largely voluntary, although there were some limitations that excluded certain patient populations, such as end-stage renal disease patients, from enrolling in Medicare Advantage plans. A lot of that is being lifted, and there's actually a bigger push to educate patients about Medicare Advantage, and it's actually a big growth area. But these are patients that, to the hospital, to the physician, to any number of providers, it looks like a commercial patient. It looks like they have a United Healthcare plan. The card, their insurance card, should indicate that they're a Medicare Advantage plan, but otherwise, it looks commercial. When we talk about overpayments coming up later, we have to think about, however, that even though it looks commercial, it's still a government plan, so it should be treated as such. So, and a lot of beneficiaries choose to do Part C, Medicare Advantage, and Part D, the prescription drug benefit, together, and those are called Medicare Advantage prescription drug plans, MAPD plans. Going to the next slide, the services that are covered, a Medicare Advantage plan has to cover everything that Medicare can cover, or Medicare covers. So all Part A and Part B services have to be covered. They're supposed to follow the national coverage determinations and local coverage determinations for Medicare, meaning if you know the rules of the coverage rules, excuse me, not necessarily the payment rules, but the coverage rules associated with the service, those should also apply to Medicare Advantage. They can, however, offer supplemental benefits, and this is where a lot of people choose to go into a Medicare Advantage plan rather than straight Medicare, because you can get the expanded benefit package. And then their cost-sharing obligations are pretty much defined by plan, and so this is one of those things that we think of. You have to think of it as a government plan, but a lot of it is actually driven by the contract that you have with the plan, or that the plan has with CMS, or their various coverage and payment rules. So a little bit more flexibility in the Medicare Advantage space. In general, the payment is dependent on the contract that you have. So you can contract independently with the Medicare Advantage plan. So let's say your facility is doing contract negotiations with United Healthcare. What you'll typically see is a very thick contract that covers their commercial patients, and then there's a Medicare Advantage addendum at the end that may or may not have special payment rules or terms for the Medicare Advantage population. Oftentimes, they're going to try to drive down to Medicare rates for Medicare Advantage plans, but there are providers that are successful in getting an increased rate on Medicare Advantage, so there's some advantage to negotiating with those plans. However, you can be non-contracted with Medicare Advantage plan. And in that instance, they have to pay you at least what Medicare pays you. And there's been a ton of discussion over the years around what that means. And because there's some confusion, because Medicare Advantage might not have the same payment methodology, for instance, as Medicare. And so what does it mean to pay us just like Medicare? In the end-stage renal disease context, we see this because the payment methodologies vary significantly, and like what you have to provide and bill for, and who bills for what services varies significantly. And so that discussion can be difficult sometimes, but you should anticipate where you don't have those discrepancies, that the payment would be the same. And that is a short section because it's largely driven by your individual contract. And I will turn it over to Sara to talk about the prescription drug benefit.
Yeah, and the same is true here. This is a relatively short couple of slides here because it is, again, similar to Medicare Advantage and Part C, is largely driven by private contracts and negotiations. There's much more to Medicare Advantage and to Part D than we've been able to cover here, but we wanted to focus on Part A and B and original Medicare because it really forms the basis for understanding Medicare at a fundamental level. But Part D, again, similar to Part C in the sense that Medicare CMS contracts with private commercial plans to provide a prescription drug benefit plan. But unlike Medicare Advantage, Part D is effectively in addition to Parts A and B. It's not an alternative or replacement. It's additional coverage for drugs that are not otherwise covered under Parts A and B. As Bragg said, the plans can be purchased as part of a dual MA-PD plan, but Part D can also be purchased as a standalone to go with original Medicare, the Part A and B. So it is a voluntary program. There are additional premiums associated with the plans to get that extra coverage. The drugs covered by the Part D plan, it depends on the plan, but you have to meet certain baseline requirements, have to be FDA-approved drugs that are furnished for a medically accepted indication, and they have to be drugs that are not otherwise covered under Part A, Part B, or those that are excluded under Medicaid. Beneficiaries, there is a standard plan that beneficiaries can buy into better plans that have lower deductibles or more coverage, so enhanced benefit packages. And it just really depends on how much you want to spend and for how much coverage and how little out of pocket you want to pay for those drugs. As far as payment for the actual pharmacies and providers that contract with Part D plans, the payment that goes from Part D to the plans is the product of commercial negotiation. So similar to Medicare Advantage in that sense. And there's actually a statute in place that prohibits Medicare from interfering, Medicare and the government generally from interfering with payment negotiations between Part D and pharmacies. Although, you may be aware there's a lot of discussion around right now politically to bring down the cost of drugs. But they have not, there's this clause in the statute, and they have not, as of yet, made any moves to try to control drug costs through the Part D mechanism. So, for the time being, the rates are strictly a matter of private negotiation. And I'll kick it back to you, Bragg, to talk about the evolving payment methodologies.
Great. If everybody wants to take a stretch, you've learned a whole lot of stuff, and now I'm going to tell you to forget some of it. There's a lot going on at CMS, a lot of experimentation going on to move payment models even further along the spectrum from volume to value. And they are somewhat limited in this because of the various parts of Medicare. I mean, there are different structures that are defined by Congress, old statutes that define, Part A and Part B and Part C and Part D. And so experimenting at the agency level can be a little bit difficult because you are still bound by those statutory constructs. But we are sort of thinking, as we think about this evolving payment methodologies, we look at things like, we started at fee-for-service. The more you did, the more you got paid. Then fee-for-service / prospective payment system, and we're going to add some quality to it. And then we're going to move to what they call advanced payment models, which could be things like, there are a bunch of different kinds, but when we start thinking about Medicare shared savings programs, for instance, which are programs where you can participate and you get aligned with a variety of different types of providers, ranging from physicians to hospitals, and you can get paid back a percentage of some of the savings that you have. But you still continue to get paid under whatever program you would otherwise get paid. You still bill the same way you've always billed. But if you are on the side coordinating through accountable care organizations or the like, which include the hospital, the long-term care facility, the physician, that sort of thing, you've got a separate agreement with them. You can all share in those savings. And then moving more towards what we'll talk about in a second, providers and advanced payment models or advanced APMs, where they take some risk. And so they'll take sort of a financial risk for making sure that the patient gets the best care at the least amount of cost. And so as we talk about this, we're going to talk about a couple of different programs. There are a lot. There is an organization within CMS called the Centers for Medicare and Medicaid Innovation. And if you just go to their website, I mean, there are programs that are popping in and out all the time. They're just experimenting with how do we how do we get all of this together to make sure that we are paying for the best care delivery model that we can, again, within the statutory structures that they have. So I'm just going to go over a couple of them, and then if you have questions, you can always reach out to us and ask about other programs. So starting with quality, we talked about this very briefly in the Part A section, but many of the PPS systems, probably all of the PPS systems now have some quality component to them. And so it's not enough that you provide the care, and it's not enough that you can take a win and a loss depending on how efficiently you provide care. They're going to add this quality component to it. And again, that's moving from volume to value. So you can't just say, oh yeah, we can save a bunch of money in this program and we're going to start discharging all of our patients at 3 days, because that might not be right. They saw a increase in hospital readmissions, and so we're going to add a payment component that is structured based on hospital readmissions, which we'll go through. But interestingly, and this always surprises me, is that this quality discussion didn't start until 2002, which was at this point, quite a ways ago. But if you think about the whole spectrum of healthcare and however many years that we've been talking about this is still relatively in its infancy. So they're still trying to figure it out. So I'm going to go to the next slide, and we're going to talk about the quality programs applicable to hospitals, just as an example. So the inpatient quality reporting program, this is just a reporting program. It doesn't matter how you do on the measures that they're talking about, but you have to report them. So you're required to report data on CMS selected measures in order to receive your full annual percentage increase in payment. If you don't report, your payment is reduced by a quarter of the applicable percentage increase in your annual update. And so if you report, you get your update. If you don't, you get a decrease. The value-based purchasing program moves more towards performance-based metrics. This is a payment adjustment for hospitals for inpatient services based on a standard, based on a set of CMS-determined core measures, which are adjusted annually. So if you meet the measures, you get the incentive. If not, you don't. And so that is one of the measures. Hospital-acquired conditions, again, this is an area that as they were moving from fee-for-service to the DRG system, and we're looking at what the impact is, and they were looking at a lot of data around high-cost care in hospitals, and realized that the cost of care and the mortality rates go way up because of hospital-acquired conditions. So the best way to get people to really focus on those issues is to add a payment incentive to it. So this is an incentive for hospitals to reduce hospital-acquired conditions. And the worst performing quartile of hospitals receives a 1% negative payment adjustment. So it's incentivizing you to stay at least in the top 75% of hospitals with respect to hospital-acquired conditions. And as I mentioned before, the hospital readmissions reduction program requires a reduction of up to 3% to hospitals' base operating DRG. So it just reduces your base payment essentially to account for excessive readmissions. And there are 6 different areas that are measured, and you're compared to a peer group in this measure. So it's sort of a lot to manage as a hospital, right? You've got all of the various coverage rules. If you're also managing the physicians or employed physicians, you have to learn all Part B rules, and you have to do all these different things. And oh, by the way, there's a lot that we have to report and keep track of so that we don't get all of these penalties. And this administration actually has been very focused on burden reduction. It's one of their top goals with HHS right now. And so they are starting to look, and I think all the administrations since these programs have been implemented have thought about this, but they're more articulated now in the rulemaking and looking at burden reduction. So we've got 4 different programs listed here. You're all measuring different things. Come on, CMS, why don't you just pick the things that are important and we'll focus on those, like that you can comment. But CMS just needs to pick what they're focused on, and then we'll report it, we'll focus on it, and we'll fix it. And they're starting to hear that message. So in this year's rulemaking in particular, we saw a lot of deduplication of measures. So, you don't have to report the same thing in each of the 4 programs. As long as you're reporting it in one of them, they get that. So they're starting to ease up on some of these things, but certainly not losing focus on quality. The next evolving payment methodology is more on the physician side, and it is a result of the Medicare Access and CHIP Reauthorization Act of 2015, otherwise known as MACRA. And I'm having a hard time letting go of this next bullet point. It was bipartisan legislation enacted in April 16th of 2015. Fairly certain that's one of the last bipartisan anything that has happened in Congress. And some of you may have heard, it was all over the news when this was getting enacted, is that there kept being scheduled this payment cut for physicians in Medicare, significant payment cut. And then every year they would sort of Band-Aid it up and push it on. And finally they got around to creating a system, a longer-term system to pay physicians that add that quality component. So we're not just talking about physician fee schedule anymore and fee for service. We're going to figure out a way to incentivize physicians to come along in this evolving payment methodology. And so MACRA is what did that. And CMS coined the MACRA program, the Quality Payment Program, and it's really focused on value and outcomes for physician payment and not sort of volume-based care. Now, realizing that there are physicians that are, sort of a one-physician practice in small communities, and then there are also sort of these mega physician groups, they came up with 2 different models because how you practice is going to be different in those 2 settings. So the first one, which is the default position, is the Merit-Based Incentive Payment System, or MIPS. And then the second track is the Advanced Alternative Payment Model System. And so if you go to the next slide, Sara, the first track, or MIPS, is performance-based. It's a performance-based adjustment. So you've got, if you're an eligible MIPS physician or clinician, which includes physicians, PAs, NPs, CNSs, CRNAs. In the proposed rule this year, they're proposing to add clinical psychologists, PTs, OTs, and social workers. If you're one of those physicians and you're not otherwise excluded, you're going to be required to report in certain measures, and your payment is going to be adjusted based on your performance of those measures. To be excluded from this, you have to be a low-volume clinician, sort of our 1 or 2 physician shops. So they define it by patient volume, or if you're newly enrolled, they will give you some time to get up to speed. And then if you participate in the second payment model, which I'll talk about in just a moment, you don't simultaneously have to participate in this one. So the 4 categories that they are tracking with respect to MIPS are quality, cost, improvement activities, and promoting interoperability. And the weights of the various components change over time. But depending on how you do on these scores, they compare it to a threshold that's determined every year, and then you receive a positive, negative, or neutral adjustment. So this year you're looking at a positive, negative, or neutral adjustment, well, not neutral, but a positive or negative adjustment at 5%. That goes up over time as clinicians get more involved in this, but really trying to cut costs, increase quality, and increase our productivity and interoperability of using electronic health records, which is also a huge priority across the healthcare spectrum. And so making sure that clinicians are kind of following along so that they can access hospital records and vice versa, and doing so in a secure manner. So the next slide is track 2, and this is for physicians who are willing, or physicians or groups who are willing to take a little bit more risk on a payment side, but there's a greater upside. So you're going to get a bigger payment if you're also willing to accept more financial risk. And again, I sound like a broken record, but again, the incentives are to provide high quality, effective care. And in their view, if you're able to do that, you deserve a higher payment. So a couple of different components to this. If you participate in an advanced APM program, which I'll talk about in a moment, you are eligible for a lump sum 5% bonus payment for your base year Part B services. You're exempt from the reporting under MIP, but this is kind of a false sales strategy because there is reporting through your advanced APM. And starting in 2026, if you're participating in an advanced payment model, you get a higher percentage of your base rate goes up by a higher percentage. So 0.75% in 2026 for clinicians participating in APMs, and only 25% or 0.25%, excuse me, if you're participating in MIP. So there's a good amount of upside to participate. Now, when we talk about alternative payment models, not all APMs are created equal, and in order to participate in this second track, you have to be participating in an advanced APM, and there are requirements laid out, and there are a lot of acronyms in here, which I'm not going to go into in too much detail, but one, the clinician or the group has to be using the certified EHR technology. You have to have your payments linked to quality measures. You have to take financial risk, meaning you get X amount of money and you have to care for that patient along the spectrum for that amount of money. And there are various models of this financial risk. There's Medicare shared savings programs, different tracks of that, different things that you can do. Accountable care organizations, different clinically integrated networks that are trying to get physicians and even hospitals and other providers to get on the same page with how to efficiently treat patient care. And so if you're participating in one of those, then even though the other participants are not physicians or clinicians, the clinician can take advantage of these models and reap the benefits of that. And then there are certain patient and payment counts that you have to meet over time, depending on what year it is and how many Medicare patients you're seeing and what percentage of them are Medicare versus commercial patients. And on the next slide, this is just a timeline. This shows sort of how we're moving from the fee schedule, and as you'll see, like we're no longer updating the fee schedule amount. So physicians aren't expecting a raise every year. It's going to flatten out, and then over time, the percent available to you, the percent of adjustment available to you goes up over time. So you could take a big hit, or you could get a big upside. And then you'll see as you look down at the advanced APM models that that percentage goes up quite a bit. Okay, the bundled payment models, and in the interest of time, I'm not going to go too much into this, but these are just a couple of models that we pulled out of the CMMI, or the Center for Medicare and Medicaid Innovation Programs. These are the ones that you kind of got to track pretty closely. So these are a variety of different programs that are based on the type of care a beneficiary needs, so maybe related to joint replacement or cardiac care. Each of the programs will define what DRGs are able to participate in the program. They also will decide whether or not it's a mandatory or elective program. Typically is not national, so they come up with a program and they want to test it somewhere, and so they come up with the zip codes essentially that have to participate in the program. Or it can be elective, and they'll give sort of some upside to folks for participating. And similar to accountable care organizations, where you're trying to get everybody to come along across the spectrum of care, trying to get everybody to come along and be on the same page with respect to how to care for a patient. These are models where they are trying to cross that sort of Part A, Part B border to get everybody on the same page. And if you can find savings, essentially, against the target price, then you all get to share in those savings or get the financial risk associated with that. Like I talked about, most of these programs historically have been, okay, everybody's going to keep billing for their own service, but separately we're going to figure out how we're going to make it all work so we all save money, and then the check gets written back to the hospital every time. The check goes back to the hospital. So you have to be really well coordinated to know how much am I going to get of that hospital payment clinician, for instance, will seek payment directly from the hospital, not from Medicare. So there are a variety of different models. These are evolving and changing. Like I said, there's a ton of experimenting going on. So as you get more in depth with Medicare, this is definitely an area that you'll want to focus on, because it's kind of throwing a lot of our general understandings about how folks are paid out the window. And then I'm going to go very quickly through overpayment. And this really is a fundamental concept to Medicare reimbursement, because over time, the penalties for getting it wrong have gone up and up and up. Most recently, they have tied, well, in 2010, they tied the knowing retention of an overpayment to a False Claims Act liability. So typically when we think of False Claims Act liability, we think of billing for a service you didn't actually provide, or billing for a service that wasn't medically necessary. Your claim is incorrect. You're going to, that doctor is in trouble with Medicare, so you're just going to bill it under the other doctor's name. And, there's this scheme to bill it incorrectly. And so you have a prospective or an affirmative false claim that's going out the door. These are situations often that would also constitute an overpayment, those scenarios I just mentioned, but it could also be an error that Medicare made in the payment. Your claim may be completely accurate, could be for a medically necessary service, but something happened and you got overpaid. It could be that you find out later that we didn't really have the right documentation to support payment for some subset of claims. And if you can't document medical necessity based on your medical record, then Medicare shouldn't have paid you, or would not have paid you had they known that. And so now you're sitting on an overpayment, and then we get rules that sort of identify how we resolve this problem. Like, okay, we've got an overpayment, what do we do? And the rule has come out that you must report and return an overpayment within 60 days of the date on which the overpayment was identified. The word identified is really important. We still hear providers say, somebody called our hotline and said that we billed for X, Y, and Z, and it was incorrect. We have 60 days to figure the whole thing out and pay it back. That's not true. The rulemaking did give us a 6-month time period. So after we get that hotline call, we have a period of reasonable diligence. So we get a 6-month time period to audit, to investigate, to figure out what actually happened. And then our 60-day clock starts the day we say, okay, we've done a full audit, we've figured this out, here are the claims that have been overpaid, and here is the dollar amount that ties to those claims. I'm ready to write a check. Then you've got 60 days to get it out the door. And so we think about this, Sarah, if you go to that picture, the timeline picture. So credible information. Credible information is where we start. This is the hotline call. This is you're doing a compliance audit on something completely unrelated to the issue that comes up, but doing a claims audit, you discover that you're missing inpatient orders for a subset of claims. And so then we say, well, I think we've got an issue on signatures for inpatient orders. That kicks off your timing. You've got 6 months to research and audit and figure out what's going on with your inpatient orders. Is there a problem? What's the rule? This is the time period that I would engage counsel if needed, if you think that this is a big issue and needs to be directed by counsel in order to put it under attorney-client privilege. That's important. Because things like inpatient orders, the rules are changing. And so how do we think about it now? Like, now we don't need a signed inpatient order, but we did last year. And so but really, do I have to refund even though now they don't think that's necessary? That 6 months, all of those decisions should be made within that 6 months. Once you identify, meaning that you've done that and you can quantify it, you've got 60 days to report and return. That 6 months, I should say, isn't set in stone. It's not in the rule, but it's written in what we call the preamble. And so it gives us an idea of what CMS is expecting. If CMS, or more importantly, if the Department of Justice feels like you're sticking your head in the sand and not following up on things, they will bring a case, and they have brought cases around that where you're just like not doing anything about it. If you can show you've got active involvement from your auditors and your legal staff, and you really are looking at it, but it's a really complicated issue. I haven't seen any cases where you go 7 months and they're bringing that case. It really, so far, has been a longer term head in the sand kind of scenario. So really, really important. The other thing I want to highlight before I open it up to just a couple minutes of questions is this applies, the False Claims Act applies to payments made under Titles 18 and 19, which is Medicare and Medicaid. And we just spent an hour and a half talking about all of the various programs under Medicare. So the statute applies across the board. So don't forget about your Medicare Advantage plans. Don't forget about Medicaid managed care, like all those things we have to consider. For other reasons, we should also think about things like the VA and TRICARE, where government money is involved directly or indirectly. We should pay attention to it. But also remember that not like the same payment rules don't necessarily apply across that spectrum. So when you think you have an overpayment and people are saying, well, Medicare requires X, Y, and Z, it's okay to raise your hand and say, well, it's Medicare Advantage. We might have a different set of rules to compare it to. There may still be an overpayment, but we may be able to carve out some of those because the rules are different. So make sure, again, you're paying attention to what coverage rules, what payment rules, and what part of Medicare you are under when deciding whether or not to refund money. There are also rules around cost-based overpayments, so those facilities that are paid on the basis of cost. You do separate rules. So at the time your cost report is due is when you're supposed to refund and reconcile those. There are requirements to do retroactive. You might discover in a cost report this year that you've had an error that goes years back that the auditors didn't find. This is incredibly complicated because of the lag time in when cost reports are closed. So we have to sit around for a while and kind of go through dates and do a little bit of math to figure out what we do on the cost reports. But it's a good idea to get help if you've got a cost report based overpayment. And that is everything you possibly could want to know about Medicare. I'm kidding. There's so much to know and to remember. I hope that the deck itself is valuable to you. It's a good resource tool. Please don't hesitate anytime to reach out to Sara or I. We're happy to answer questions for you. And we can open up to questions, Nikki.
Awesome. Thank you so much, Bragg and Sara, for tag teaming this presentation. So really quickly, before we jump into the Q&A, just want to remind everyone to type their question into the questions chat panel located to the right of your screen. And we will answer as many as time will allow. Also to the right of your screen is where you can find copies of the slides that Bragg was just mentioning. I agree, they are very information rich, so feel free to gain access to those right away. All right, so a question that has come through is statement/question. So this was a lot of great information. Can you refer other sources to reference after today?
Sure. I mean, there's a lot of different places that you can go. I actually, and Sara, chime in if you disagree. I think that CMS's website is actually really good. They have a lot of materials from like fact sheets that they do for different payment models. They have the manuals are pretty good at sort of getting you to the right place. You can sign up on various listservs on CMS so you can get updated when things change, depending on what type of facility you're in. It's just they have a lot of information on the website, and sometimes it's varied, but for the most part, I think it's fairly easy to navigate. And if you sign up for the what's called MedLearns articles, they're pretty easy to read. They're basic, high-level descriptions of the requirements. Sometimes, most of the time, I'd recommend doing a little bit deeper dive if you've got a particular issue. But it's a good way to just read a quick summary of something and figure out, okay, that's how a SNF is paid and what the requirements are. So I'd recommend digging around CMS's webpage.
All right, great. Thank you for that. And then kind of along that line, If this was the fundamentals, what would you say are topics of more advanced Medicare education? Is there anything in particular that jumps out that maybe you guys didn't get a chance to cover or is deep?
Well, unfortunately, there's a ton that we didn't cover. I'm not sure if the question is around how to find it or what we consider advanced. There's a ton around. I mean, what's jumping to mind are things like dually eligible patients. So there's a whole patient population that qualifies for Medicare and Medicaid, and in those situations, you have to follow both of the rules. And how do you do that? And who gets billed first? And there's a whole section of Medicare on Medicare secondary payer. So the idea that Medicare should be secondary to other payers. So a patient has a group health plan and Medicare. I mean, a huge section of the rules, and I spend a lot of time advising patients on how to deal with those Medicare secondary payer rules, and this new guidance on Medicare in instances where there's a liability insurer. So I mean, I could go on and on and on. I mean, it's evolving, and it's evolving quickly. So things are coming out of CMMI, things like new administrations. We get new rules. Sara talked about provider-based departments, site control payments. They're really focusing on whether or not hospitals should get paid anymore for services that can be offered in this office. So, I mean, it really depends on what sector you're in to figure out what the sort of Medicare 202 is, but there's just a lot.
Yeah. Well said. No, that's very fair. Okay, so I want to be respectful of everyone's time. I do want to thank everyone for joining us today. As I mentioned in the intro, this is part 2 of a 4-part series, and the next installment is scheduled for October 25th, and it's titled The Medicare Cost Report and Uncompensated Care Reimbursement. So there is still time to reserve your seat if you haven't already. Just visit Colorado HFMA's site at www.hfma-co.org. Quick reminder, as you exit, you will be automatically routed to a survey. And again, we would love your feedback. Thank you, Bragg and Sara of Polsinelli. We really appreciate you taking the time to prepare and share your knowledge and insight with our audience today. Thanks, guys.
Thank you.
All right. Thanks, everyone, again for joining, and have a great afternoon.